Hello.
Hi, Manisha.
Good afternoon, sir.
Good afternoon. Hi, Asmita.
Good afternoon.
You check the slides, na, Manisha?
What? Yes, sir.
You check the PPT, na?
Yes, sir.
Is something coming in between?
Now is it okay, sir?
No, there is some box coming in. Now it's okay. Now it's.
Yeah.
Navita is joining in 2 minutes. Then we will start.
Okay, sir.
Tech team, who is there? Asmita is there?
Yes, sir.
Asmita?
Yes, sir.
अभी रूम ओपन नहीं किया है ना?
Hello.
हाँ, just wait for 2 minutes. हाँ, let Navita start, then we open the room.
Hello.
Hello. Hello. Good afternoon, ma'am.
Hi, Manisha. Good afternoon. Hello, Abhishek boss.
Hi, Navita. Can we open?
Yeah, let's open. It's been 4:33.
Yeah.
Yeah, Speta, we can open. We start.
Yeah, we can start.
So, very good evening to everyone, and welcome to the 10th session of MAPMR academic sessions, which we do every month. And this time we have with us Dr. Manisha. She is a consultant in Kokilaben Dhirubhai Ambani Hospital, Navi Mumbai, and she'll be talking on electrodiagnostic. This is a very important topic for all the PGs and even for all of us who are in doing reporting EMG and CV. And before starting, I would um, invite Dr. Abhishek, who is the president of MAPMR, and Dr. Amit Mamre, who is the secretary of MAPMR, to say a few words, and then we'll take it forward.
I think it's a good initiative and we are doing good educational series for last 1 year and we hope to continue it in the next year also. Thank you, Navita.
Thank you, Dr. Abhishek. Dr. Amit? I think he has not joined, but maybe we can take the closing remarks from Amit. And before wasting time, we invite Manisha to deliver her talk on EMG and NCV. This is the main aspect because I know it is very difficult to to take electrodiagnostic in 1 hour. So, Manisha, over to you.
Yeah, thank you so much, ma'am. A very good evening to everyone. And I thank Navita ma'am and Abhishek sir and Mamre sir for giving me this opportunity to present this webinar on electrodiagnostics. As rightly said by ma'am, this is a big topic, a vast topic. To cover it in 1 hour is difficult, but let's see. So I have divided this talk into four different chapters. That is the basics of nerve conduction studies part one, nerve conduction studies part two, which I'll cover the late responses, then the basics of needle EMG and the motor unit action potential analysis. So starting with the first part, the basics of nerve conduction studies part one. So, nerve conduction studies are one of the major components of the electrodiagnostic studies, and we use nerve conduction study to study the peripheral nervous system. It helps to localize the lesion, diagnose the abnormality, identify the pathophysiology, assess the severity, prognosticate, and it also points towards etiology. Now, a meaningful analysis of the electrophysiological studies, they demand an adequate knowledge of the on precise location of skeletal muscles and peripheral nerves for accurate placement of the electrodes. We all know the elements of the peripheral nervous system. It consists of the peripheral sensory nerve, the peripheral motor nerve, the dorsal root ganglion, the anterior horn cell, the neuromuscular junction, and the muscle. Now, how does information processing in the peripheral nervous system happen? So it happens with the help of sensory and motor impulses. They propagate along the nerve fibers. In nature, impulses propagate only in the physiological or the orthodromic direction. So conduction of impulses in motor fibers, they occur from the anterior horn cell to the muscle, whereas in the sensory fibers, impulses propagate from the sensory receptor towards the dorsal root ganglion. So, but in electrodiagnostic laboratory, when we stimulate the nerve, the impulses, they go bidirectionally. So there is a bidirectional volley of impulses. So sensory and motor impulses can conduct in both the directions. So when they conduct in the direction of normal physiological responses, they are known as orthodromic conduction, and opposite, they are known as antidromic conduction. So first, let us come to let us have an introduction to the machine and equipment. So this is a machine which is used to record the nerve muscle potential, and the machine which is used to record the nerve muscle potential is known as the electromyograph. There are parts of electromyograph. So we have a head box or a preamplifier, one console, monitor, and the stimulator. So this is the head box or the preamplifier. So one head box, it has 2 channels, whereas the other head box, it shows us the 4 channels. And in this, you can see a big knob, which is for the needle electrode, one knob, which is green in color, which is for the ground electrode, one which is black in color, which is for the active recording electrode, and one which is red in color, which is the reference electrode. This is a console which has different knobs for volume adjustment. We can shuffle between traces. We can increase the stimulus intensity. And when we want to start the test, we can acquire the test or start the test, and also on button to average the responses. Mostly the sensory nerve action potentials, they need averaging because they are very small responses. We also have a foot switch which comes in certain machines, and it is helpful when we are doing a needle EMG, and when as a single person, when you are handling the patient. So when you are inserting the needle and then you want to want the patient to activate the muscle, but if the patient is not able to activate the muscle, in such conditions you have to apply resistance. So both your hands will not be free to acquire the graph which is coming. So in those cases, you can use the foot switch to start or stop. This is how a monitor of the on the electromyograph looks like, and you can see that there are different tests which are enumerated on the monitor. This is a setup of the motor nerve conduction study. So on the setup, you can see there is something which is written in the microvolt, something which is written in milliseconds. So then you can adjust the stimulus duration. You can adjust the stimulus intensity. You can see whether you want to do a single channel study or a two channel study. There are different filter settings, which nerve you are studying. Then what are the what are the stimulation sites that? Yes, ma'am. Hello, ma'am. Am I?
Yeah, you're audible. Yes,
Yeah.
go ahead.
Okay. And the different stimulation sites that we want to stimulate. And in the last box, we have a box wherein we put the distance so that we can compute the conduction velocity. Similarly, there is a setup for the sensory nerve conduction studies. So these are the stimulating electrodes. There are different stimulating electrodes. One is a handheld stimulator, which is normally used. Then there is a bar stimulator, where this is mostly used when you have to stimulate for longer periods of time. Mostly used in cases of when we want to do studies like the somatosensory electrode potentials. Then we have ring stimulators. These are used when we are looking at the digital nerves. Then there are recording electrodes, there are self-adhesive disposable electrodes, and there are shielded reusable electrodes also. We have a ground electrode, and sometimes when we want to do the SSEPs, we use the wraparound round so that we have use the ground along with the bar stimulator so that it is in place. Now, the points we have to remember are, you have to know the machine and the electrodes that you are using. You require a dedicated earthing for the machine, and regular electric safety checks should be done. And you have to follow practice parameters for each test as per the reference data followed for interpretation. Now, we have three basic types of nerve conduction study. One is a sensory nerve conduction study, second is a motor nerve conduction study, and third is a mixed nerve conduction study. So sensory nerve conduction studies, only sensory nerve fibers are assessed. Now, sensory nerve conduction study, the sensory responses are very small. Therefore, technical factors and electrical noise, they assume more importance in these studies. That is why the gain is set at 10 to 20 microseconds per division. I'll come to this as to what is a gain and what is a sweep duration. I'll explain that in the coming slides. Then a pair of recording electrodes are placed in line over the nerve being studied, and an inter-electrode distance of 2.5 to 4 centimeters is kept in between the two electrodes. We use an electrical pulse of 100 to 200 milliseconds in duration. And for sensory nerves, we require a current in the range of 5 to 30 milliamperes to achieve supramaximal stimulation. Now, when we start the study, the current is slowly increased until the recorded potential is maximized, and that recorded potential is known as a sensory nerve action potential. It is a compound potential that represents the summation of all individual sensory fiber action potentials, and snaps usually are biphasic or triphasic. This is the setup of the sensory nerve conduction study, wherein we are using ring electrodes. The black one is the active recording electrode. The red is the reference electrode. There is a ground in between, and we have a bar stimulator. Here we are recording the median nerve from digit 2. And this is an antidromic technique of recording the median nerve from digit 2. So In antidromic technique, when we record, we apply the recording electrodes distally. That is where the sensory receptors are placed, and we stimulate the nerve proximally. Whereas in orthodromic recording, we place the electrodes proximally, the recording electrodes proximally. That is, for the median nerve, we'll place the active recording electrode at the level of the proximal wrist crease, the reference electrode 3 to 4 centimeters away from the active recording electrode. We will place the ground on the in the palm, and then we will start stimulating in the digit. So when we are stimulating on the digits and recording at the wrist, it is an orthodromic recording technique. And when we are recording from the digits and stimulating at the wrist, that is an antidromic recording technique. Now, what is the difference between when to use antidromic, orthodromic? There is no such criteria as to what to use, but mostly antidromic recordings, the snap potentials they are higher in amplitude, and they are used for recording very small potentials. They are less subject to noise and artifacts, but because you are stimulating the nerve when it is better exposed, you get a large volume conducted motor potential, which is not the case in cases of orthodromic recordings. This I've already explained. So this is the setup of an antidromic recording. You can see in the figure that we are recording the snap from the ulnar now, but you can see that there is something, you can see a large artifact coming up, which is a volume conducted potential coming from the ulnar motor fibers. So this is how a sensory nerve action potential looks like on the machine. So there are different parameters that we have to assess when we are looking at a sensory nerve action potential. So you can see on the screen, there is what we measure is the onset latency, peak latency, the duration, and the amplitude. So what is the onset latency? Onset latency is measured on the horizontal axis. It is a time duration. It is measured between the onset of stimulus to the initial negative deflection from the baseline. I'll show the previous slide again. So you can see there is one line which is coming up, which is an artifact, and in this recording, the baseline is not very much clear. So you have to understand where to keep the initial marker so that you can record the onset latency properly. So from the initial stimulus to the first deflection from the baseline, so that area, that distance is the onset latency. And onset latency, it represents the nerve conduction time from the stimulus site to the recording electrode for the largest cutaneous nerve fibers studied. What is peak latency? It is the time duration, again measured on the horizontal axis, between the onset of stimulus to the peak of the response, where the response peaks. It doesn't help in indicating the number of fastest conducting fibers, and it is not affected by noise or stimulus artifact, but it cannot be used to compute the conduction velocity. So we can see the three arrow marks. So this is the distance for onset latency. And then you can see one mark at the peak. So that is from the initial deflection from the baseline, that is where the stimulus starts, to the peak of the snap. That distance is the peak latency. Now, what does prolongation in latency suggest? So the prolongation in latency can occur either because of demyelination or because of axon loss. So if it is abnormal, and we have to see how much it is prolonged. If it is mild, it may be because of axon loss, but if it is significant, then it can, in the demyelinating range, then we have to see whether one nerve is affected, that is there any focus slowing, or many nerves are affected in a similar manner. So if many nerves are affected in a similar manner, that is, if there is generalized slowing, then it can be a case of generalized peripheral neuropathy. If it is only in one nerve, for example, median nerve across the wrist is affected, that is showing focus slowing, then it can be a presentation of the carpal tunnel syndrome. And if many nerves are affected and in a differential manner, so that is multifocal slowing, it can suggest, it can point towards etiology, then it can be a case of leprosy. Now, coming to amplitude, this is a voltage measurement measured on the vertical axis. It is measured from the baseline to the negative peak or from the negative peak to the positive peak. It is documented in microvolts and it reflects the sum of all individual sensory fibers that depolarize. And low sensory nerve action potential amplitudes, they indicate a definite disorder of the peripheral nerve. Again, the amplitude, if it is very low, it can be because of axon loss or it can be because of secondary demyelination. Again, you have to see whether there is any relative attenuation in the amplitude or there is an absolute attenuation of the amplitude. So when the amplitude, you have to compare with the opposite side of the patient. So if I'm looking for the median nerve snap on the right hand and if I'm looking at a median nerve snap on the left hand, and if the right to left difference is 50%, more than 50%, but when I compare it with the reference data, it is still normal. It shows relative attenuation. And when it is more than 50%, when I compare it with the reference data, then it is known as absolute attenuation. What is duration? Again, measured from the onset of potential to the first baseline crossing, that is a peak duration. It can be also measured from the initial to the terminal deflection back to the baseline. Then we call it total duration. And for snaps, we prefer peak duration. Then conduction velocity, it is the speed of conduction along a sensory nerve. It can be determined with one stimulation in cases of the sensory nerve potentials. And how do we obtain it? By dividing the distance traveled by the onset latency. And it represents the speed of fastest myelinated cutaneous sensory fibers in the nerve being studied. So conduction velocity is total distance divided by the proximal onset latency. Now coming to motor nerve conduction studies, these are technically less demanding and we perform them by a belly tendon montage method, and recording electrodes are placed over the muscle of interest and motor responses are in the range of millivolts. In snaps, they were in the range of microvolts. The current required is in the range of 20 to 50 milliamperes to achieve supramaximal stimulation, and the recorded potential is known as the compound muscle action potential. It represents the summation of all the individual under muscle fiber action potentials. And you have to see when you are recording a CMAP that you have to increase the stimulus intensity. If the CMAP does not increase in size, even after increasing the stimulus intensity, then you have achieved a supramaximal stimulation. And current is increased by 20 to 25% to ensure that supramaximal stimulation is achieved. And compound muscle action potentials are biphasic potentials. So this is the study setup for a motor nerve conduction study. The G1 is the active recording electrode. Here we are recording the compound muscle action potential from the abductor pollicis brevis or recording the median nerve. So the first G1 is placed over the abductor pollicis brevis. The G2 is placed over the tendon in the proximal phalanx. The ground is placed in between and we are stimulating the median nerve in between the FCR and the palmaris longus muscle. So for motor nerve conduction studies, we have to look at different parameters. So the parameters are again latency, amplitude, area, duration, and the conduction velocity. Now again, the how we measure the parameters, they all are similar to the sensory nerve action potential studies. The latency is again from the initial stimulus to the initial deflection from the baseline. The amplitude is the highest peak that we can see. Now the amplitude here can be from base to peak or it can be from one peak to the next peak. Then the duration is from the initial deflection from the baseline to the final crossing of the deflection to the baseline. Again, we can compute the peak duration or the total duration. And in cases of compound muscle action, the CMAPs, what is important is the computation of the conduction velocity. As I told, in cases of sensory nerve conduction studies, you require only one stimulus to compute the conduction velocity. But in cases of motor nerve studies, we have to stimulate at two sites to compute the conduction velocity. Why? Because when I am looking at the latency, when I am stimulating a motor nerve, so the latency reflects how the stimulus is traveling from the site of stimulation to the nerve and from the nerve to the muscles. And there is also a depolarization time and a time lag which is occurring at the neuromuscular junction. When I am stimulating at only one side, I'll get the conduction at the velocity at a distal segment. And if I have to calculate the conduction velocity for that particular nerve, I have to stimulate for the median nerve at the wrist and again at the elbow. Then only I'll get the conduction velocity at the in the forearm segment. So that's why we require two stimulation sites. One is proximal and one distal. Now, mixed conduction studies are comparable to sensory studies, and these potentials reflect both motor and sensory fiber action potentials. And mostly these studies are performed on medial, ulnar, and the distal tibial nerves. They record again the largest and the fastest fibers. And the motor nerve conduction velocity are faster than motor or sensory nerve conduction velocities. Mixed nerve conduction velocities, they are faster. That is why when we record the plantar nerves, the snaps from the plantar nerves, we see the conduction velocities are much larger as compared to the velocities from the sural or the superficial peroneal nerve. And the recorded potential is known as the mixed nerve action potentials. They are also again biphasic or triphasic. Parameters measured are similar to the sensory nerve or the motor nerve conduction studies. So again, a setup on the machine showing a mixed nerve conduction study. This here we are recording from the left medial plantar and the lateral plantar nerve. You can see there is one small potential that you can see on the screen, which is the mixed nerve potential, and then followed by a large motor potential. So this is how we do a mixed nerve studies. If we don't know how to stimulate, then sometimes we may take the motor potential to be the snap. With in those cases, then it is wrong. We have not recorded the snaps, the mixed nerve studies properly. So we have to know which is a snap and which is the C map, which is that is what we are seeing on the screen. Now, the principles of stimulation are only two. You have to use supramaximal stimulation because nerves follow the all or none phenomena, and you have to optimize the stimulation side. Because if you are away, if you are recording the stimulating electrode is away from the actual site, again you will not be able to uh, you will not be able to get the snap or the CMAP. And if your the stimulus intensity is also low, the amplitude that you are getting will be low. And even if the patient is not having any disease state, you can label the patient as having a certain problem. So this is the example of supramaximal stimulation. Here we were recording the left radial snap. So you can see when the stimulus intensity was 7 milliamperes, the amplitude was only 8.3 microvolts. But as I went on increasing the stimulus intensity to 12.2 milliamperes, the amplitude increased to 38.5 microvolts. Again, I increase the stimulus intensity to 22, then the amplitude remains unchanged. That is why supramaximal stimulation is very important. I'll just show how what is sweep and gain. So on the horizontal axis, you can see that there are some numbers which are in microvolts on the left hand side and milliseconds on the right hand side. So the number with the milliseconds on the right hand side, that is the sweep. That is how fast the trace is moving. And on the left hand side, you can see something in microvolts. That is the gain. So this here the gain is set to 10 microvolts and the sweep is set to 2 milliseconds. So if your machine settings are good and they are set at a particular setup, then only you will be able to see a snap. So in the first picture, you can see the snap is with optimum sweep. Now, if you reduce the sweep to 500 microseconds, you can see the snap is a little splayed. And when you increase the sweep from 2 milliseconds to 5 milliseconds, you will see that you are not able to see the snap. The snap will be buried on the left hand side along with the stimulus artifact. That is why you have to know the settings of the machine. Now, stimulus artifact is also important. Why? Because then you know that at least the machine is working, and as it decays, you can take the time from the stimulus artifact where the stimulus artifact ends to the initial deflection in order to compute the latencies. Now, coming to a very important part, what is the role of dorsal root ganglion in localizing lesions? The cell bodies of the sensory nerve fibers are in the dorsal root ganglion, but dorsal root ganglion is situated at the level of intervertebral foramina and they are not intraspinal. So now when we record the sensory nerve action potential, it reflects the integrity of the dorsal root ganglion cells and their peripheral axons. Hence, SNAP helps to localize nerve disorders. So if in any of the study when I am recording from the median nerve or I am recording from the lower limb and I am looking at the sural nerve, and if I am not getting a SNAP recorded, then I can make the diagnosis at that very time that what am I dealing with? Am I dealing with a neuropathy or a radiculopathy? Because in cases of neuropathy, that is nerve disorders, the SNAPs will be absent. But in cases of radiculopathy, the SNAP will be present. So an absent or reduced SNAP indicates abnormality at or distal to the dorsal root ganglion. That is, the lesion is always post-ganglionic. Which can happen in cases of plexopathy, neuropathy, polyneuropathy, and peripheral nerve injury, or it can be a case of sensory neuronopathy. But in cases of radiculopathy, the lesion is always pre-ganglionic. So SNAP will always be present. Pre-ganglionic lesion affects the central nervous system fibers between the dorsal root ganglion and the spinal cord, and it spares the dorsal root ganglion. So that is why in pre-ganglionic lesions, the SNAP is normal. That is, we can see such things in radiculopathies and root avulsions. So preserved SNAP helps us to differentiate pre-ganglionic from the post-ganglionic disorders. Coming to the second part of the nerve conduction studies, that is the late responses. Now, routinely, we assess the nerves in the distal nerve segments. So that is why we have to assess the nerve proximally also. So F-wave and H reflexes, they are late responses and they assess the proximal nerve segments. They also assess conduction abnormalities over nerve segments which are not tested by routine studies. And late responses interface at the level of spinal cord, so they provide valuable information about the physiology of the central nervous system. So coming to F-waves, F-wave is an artifact which is induced by external stimulation. It has no physiological function. So it results from the backfiring of the antidromically activated anterior horn cell, and it helps to assess motor conduction along the entire length of peripheral axons, including the most proximal segment. F-wave passes through the entire motor nerve from the stimulating side to the anterior horn cell via the motor route, and again it comes down the same path to the muscle where it is picked up from. Hence, any lesion along this path can affect it. So you have to give a supramaximal stimulus to the nerve at a distal site when you are doing your motor nerve conduction study. And the muscle responds in an all or none fashion. It produces a CMAP or an M response. A normal nerve in the lab, it propagates bidirectionally. So action potential that travel towards the spinal cord along the motor fibers. Once the response, it reaches the hillock of the anterior horn cell, it excites the anterior horn cell, it fires off a potential, and it again travels back to the recording electrode placed over the muscle. And then you see again a small response coming up. That response is a late response or the F wave. For F wave stimulation, we have to use supramaximal stimulations. And it is not a reflex, as the afferent and the efferent pathway is the same motor fiber. It does not, because it does not involve a synapse. So it is not a true reflex. In conditions where the sensory nerve fibers are affected, the F responses will be completely normal. And only 1% of the entire pool of anterior horn cells is known to produce F waves, preferentially the larger motor neurons. Because of this, every time when you elicit the response, the morphology of the F wave changes a bit every time, because the generator anterior horn cell is different each time. So that is why this is helpful in certain disorders. For example, when we are dealing with a patient with a motor neuron disorder and he is not having any florid changes in the muscle, and if you are recording the F waves from that patient, sometimes because the motor neuron disease differentially affects the anterior horn cell, you will see that this patient's F waves will be repeater type of F waves. The same anterior horn cell is firing again and again. So the morphology of the F waves will be similar every time. So this is the pathway of the F wave recording. The afferent is the motor fibers, efferent is again the same motor fiber, and generator is the anterior horn cell. So the setup is the same as the motor nerve conduction study, and you have to use supramaximal stimulation. At least 5 to 10, at least 10 stimulations should be used, because we have to see what type of responses are we getting every time. This is a video, I hope you are able to see this, of how we record the F waves in the laboratory. So we are recording the F waves from the right abductor hallucis muscle supplied by the tibial nerve. You can see as I am going on increasing the stimulus intensity, you can see a big M response and then a smaller response which is coming up. So that is the F waves. And you have to see for the minimal latency of the F waves and the maximal latency of the F waves. So there are different parameters that are studied when we record the F waves. The minimal F latency, the maximal F latency. What is the difference between the minimal and the maximal, which is known as the chronodispersion or the jitter? What is the persistence? Persistence is, are we getting F waves every time we are stimulating it? That is, when we are doing 10 stimulations, are we getting F waves in all the 10 stimulations, or are we getting it only in 7 stimulations? So if I am getting F waves in all the stimulations, it means that my persistence is 100%. But if I am getting in only 7 stimulations out of 10, it means that my persistence is 70%. So persistence is also important when we look at certain disorders, for example, the Guillain-Barré syndrome. And repeater F waves are very important when it comes to motor neuron diseases. But when the anterior horn cell itself, if the muscle is not having any amplitude, if the muscle has lost its amplitude, which can happen in cases of generalized peripheral neuropathy also, that times if the CMAP is only low, then you might not get any F waves. I'll not explain everything in detail because we have to complete. So, what is the significance of F waves? In demyelinating acquired peripheral neuropathies, earliest abnormality is the reduced F persistence, followed by there will be an increased jitter, that is a maximal versus minimal will increase, and there will be increased latency, and finally the F waves will be absent. Mildly prolonged F waves can be seen in length-dependent axonal neuropathies. F wave from tibial nerve stimulation is prolonged in diabetic peripheral neuropathy and may be an early sign of motor nerve involvement. Poor F persistence with normal distal CMAP amplitude is suggestive of a conduction block. F waves are not abnormal in compressive radiculopathies because in these in radiculopathies the F waves we are not recording from each and every nerve. We are recording in the lower limb from the tibial and the peroneal. The peroneal F waves have a very less persistence. That is why mostly we don't record from the peroneal nerve. We take the F waves from the tibial nerve, and in the upper limb we record F waves from the median and the ulnar nerve. So if we are looking at radiculopathies for the lower limb, they will always only help us in cases of L5S1 radiculopathies, and in the upper limb only in cases of C8T1 radiculopathies. Otherwise, they will not be helpful. Then distal entrapment of nerve will cause F wave to be prolonged from that nerve, and repeater F waves are seen in axon loss lesions. Now, limitations of the use of F waves. It is mainly because of the lack of specificity in determining the site or the cause of the lesion. F responses are not seen when the CMAP is severely reduced, and they are only 1 to 5% of the amplitude of CMAP. Hence, F responses are unobtainable or very low in amplitude and difficult to measure if the CMAP amplitudes are reduced. As F response is used to assess the proximal segment of the nerve, it can be assumed that they are useful in assessing radiculopathy or plexopathy, but they are not that useful. Why they are not useful, I've already discussed. Only in the lower limb we only assess the tibial nerve, and in the upper limb only the median and the ulnar nerve. And if radiculopathy predominantly affects the sensory fibers, the F waves will be completely normal. Coming to H reflex, again, this is a late reflex, but this is a true reflex because it involves a sensory afferent, a synapse, and a motor efferent. And H reflexes can be elicited from the tibial nerve recording the gastrosoleus, from the femoral nerve recording the quadriceps, from the median nerve recording the flexor carpi radialis, and occasionally in the plantar foot muscles. This is the circuit of the H reflex. The afferent is from the group 1A sensory fibers. Efferent are the motor fibers. They can mean the root, plexus, or nerve, and neuron is the anterior horn cell. And because it is a synapse, it has a synapse. Therefore, this is a true reflex. This is the setup of the H reflex. Here we are showing two setups. One H reflex we are recording from the flexor carpi radialis muscle stimulating the median nerve. And another we are recording from the gastrosoleus stimulating the tibial nerve. For H reflex setup, normally when we stimulate the motor nerves, we keep the cathode towards the muscle of interest. But when we are recording the H reflex, we have to keep the cathode towards the spinal cord. This is a graph showing the H reflexes, how we obtain the H reflexes. For H reflexes, for F waves, we have to use supramaximal stimulation, but for H reflexes, you have to use submaximal stimulation. Why we are using submaximal stimulation? Because when we are using submaximal stimulation, you are stimulating only the group 1A sensory fibers. And the firing of the group 1A sensory fibers, it goes to the anterior horn cell, comes back, and then we record the H reflex. When we are slowly increasing the stimulus intensity, what happens is the 1A sensory fibers will be activated. Similarly, the motor fibers will also be activated. So there will be a cancellation of impulses which occur when they come back. Therefore, with larger stimulus intensity, there will occur more cancellation. So that is why we use a very small submaximal stimulation so that we only stimulate the group 1A sensory fibers. And if we keep on increasing the stimulus intensity, instead of the H reflexes, we might get the F waves. This is a video showing how we see for the H reflexes from the tibial soleus, from the left tibial soleus. So with I'm increasing the stimulus intensity very little from 5 to 9, 9 to 10. And the first H reflex I got is at 12, 13 milliamperes. Again, going on increasing the stimulus intensity until the H reflex amplitude increases. And then with increasing stimulus intensity, you can see the H reflex amplitude has again come down. This is mainly because there occurs cancellation of the impulses along the sensory and the motor fibers. What are the parameters measured? Again, we measure the onset latency measured at the first deflection from the baseline. We measure the amplitude, which is peak to peak amplitude, and we measure the M wave to the H amplitude ratio. So for example, in this case, the H reflex from the right tibial soleus is obtained, and you can see the marker is placed from the initial deflection from the baseline, and the H reflex latency in this case is 31.09 milliseconds, and the H reflex amplitude is 5.2 millivolts. So what do absence of H reflex indicate? Absent H reflexes can be seen in cases of early Guillain-Barré syndrome, low central excitability, sensory ganglionopathy, axon loss lesions, or if the afferent volley is desynchronized. So H reflex from soleus will also be absent in length-dependent peripheral neuropathy, or it can be an early indicator of length-dependent peripheral neuropathy also. And presence of H reflex with significant peripheral neuropathy on NCS suggests mononeuritis multiplex. H reflex present in an actively denervated muscle suggests a combination of upper motor neuron and lower motor neuron lesion, most likely a motor neuron disorder. So if there is a case of a motor neuron disorder, we definitely see for whether we are getting H reflex from a denervated muscle. Or we can also see whether the patient has some UMN sign, then we have to see the H reflex again from the flexor carpi radialis muscle. So presence of H reflex from a rested muscle other than soleus or FCRs, it is suggestive of a upper motor neuron lesion. And large amplitude H reflex, again, it suggests motor neuronal hyperactivity. In obese subjects, we may require higher stimulus intensity to be given because the tibial nerve, which is because we stimulate at the level of popliteal fossa, so the stimulus has to reach to the nerve, so we have to increase the stimulus intensity. If still we are not getting the H reflex, we can ask the patient to do a Gendrasix maneuver or ask the patient to do a plantar flexion. This may enhance H reflex. If H reflex is not obtained, but if ankle jerk is present clinically, then we know that there is some technical problem because H reflex is a clinical correlate of the ankle jerk. So if ankle jerk is present, we should be able to get the H reflex. Then there is something known in electrodiagnostics, something known as a repetitive nerve stimulation also. Repetitive nerve stimulation studies are mostly used to diagnose neuromuscular junction disorders. We can use the slow repetitive nerve stimulation or the fast repetitive nerve stimulation, and also to distinguish between whether it is a presynaptic or a postsynaptic neuromuscular junction disorder. Coming to needle EMG, again, electromyography or needle electrode examination is used to study the electrical activity of the muscle. We use disposable needle electrodes. Now, this is a challenging examination because it is an audiovisual diagnosis. It requires more expertise because with experience you will understand what are the different sounds that you are hearing and what are the different what you have to look at when you are looking at the graph. And it is used to diagnose patients with lower motor dysfunction to identify the site, severity, extent, and the distribution of abnormality. It is useful in patients with only sensory symptoms to determine subclinical motor involvement. It helps to detect axon regeneration, therefore, it is also useful in prognosis. Useful in therapeutics for botulinum toxin injection, and also useful in intraoperative neuromonitoring. So what is the equipment required? Again, we require the EMG machine, the EMG needle, the needle cable, ground electrodes, and the gloves. We already know the EMG machine. There are three different types of needle electrodes that we can use. We can use the concentric needle electrode, the monopolar needle electrode, and the single fiber needle electrode. We mostly use the concentric needle electrode. The concentric needle electrode contains both the active and the reference electrodes in the needle itself. And the shaft of the needle serves as a reference electrode, and the active electrode runs as a very small wire through the center of the needle. It is exposed at the tip, and the end of the concentric needle is beveled. Hence, the recording area has a teardrop configuration. It is less noisy, but it is more painful, and motor unit potential is smaller in amplitude when we record with this concentric needle electrode. In cases of monopolar needle electrode, it is Teflon coated. Its exposed end serves as an active recording electrode. You have to use an additional disc electrode, which serves as a reference. The recording area is in the shape of sphere. It is more noisy but less painful. And because you are using an additional reference electrode, there will be greater likelihood of electrode impedance mismatch. And motor unit potential is larger with this needle electrode. Then we have something known as a single fiber needle electrode. So there is this is a electrode which has an active recording electrode. It has a wire which is inserted into the cannula, and it is bent a few millimeters before the tip and is exposed from the side port. The recording area is very smaller, and it is used only for muscle fiber density measurements, mostly if we have any confusion with respect to the neuromuscular junction disorder. How do we go about the needle examination? You have to explain the procedure to the patient because it is a painful procedure. You have to select the muscle for study, locate the muscle using anatomic landmarks, show the patient how to activate the muscle, palpate the muscle during contraction, ask the patient to again relax the muscle, insert the needle into the relaxed muscle, again ask the patient to gently contract the muscle to ensure proper placement, then again ask the patient to fully relax fully. Then you check for the insertional activity and the spontaneous activity. Ask the patient to contract slightly. Then we assess the motor unit action potentials. We do an analysis of motor unit action potentials, and then we proceed to the next muscle. So what is the principle of needle electrode examination? You have to bracket the lesion by examining at least one normal muscle above and below the lesion. And the study should determine why the muscle is weak, what is the disturbance or the pattern of involvement, whether there is any subclinical involvement of other muscle, whether there is any pattern which helps to determine the etiology, and whether there is any recovery in traumatic nerve lesions, and if there is any recovery, how distal the recovery has extended. So we have to follow these steps. When we insert the needle into a relaxed muscle, we check for the insertional activity. When the muscle is at rest, we look at the spontaneous activity. With mild voluntary contraction, we do the motor unit action potential analysis. And with maximum voluntary contraction, we look at the interference pattern. This is a video showing how we do the needle electrode examination. So the patient is completely relaxed, muscle is at rest, gently contracting. We can see some motor unit action potential coming. Again, it is contracting fully. We can see there is not many So insertional activities, it is seen in a normal muscle when the needle is moved with the muscle, and the source is mostly muscle fibers which are irritated by the needle, and then that is why they fire off an action potential. It is important because with the help of the insertional activity, you can confirm that the needle is in the muscle. And they are seen as small bursts, and these bursts occur only with needle movement, and they have a they have short, small potentials. And when you stop moving the needle, the activity stops. So the activity only when we are putting the needle, and when we are stopping the needle movement. Coming at spontaneous activity, it is the activity picked up from the muscle at rest, defined as an activity that lasts for more than 3 seconds after the needle has stopped moving. So sometimes you have to see on the screen and whether you are seeing the same activity for 3 seconds or not, or more than 3 seconds. Otherwise, you will falsely give the diagnosis of having fibrillation potentials or positive sharp waves in the report. Normal muscle does not have any spontaneous activity except at the end plate region, wherein you will get the end plate noise and the end plate spike. That is why it is important to identify the type of spontaneous activity, because the type of spontaneous activity indicates the generator along the motor unit, and it helps in localizing the site of lesion. So the following parameters need to be assessed when spontaneous activity is detected. Presence of spontaneous activity, it gives an idea of the time course. Distribution of whether is it in the nerve, in the root, or has a more widespread pattern. Type of activity gives a clue to the disease process, and degree of spontaneous activity may assess the severity of lesion. So the spontaneous activity can come from a muscle fiber. When it is from a muscle fiber, it can be a fibrillation potential or a positive sharp wave or a myotonia. When it is when I already told that muscle is electrically silent at rest. So except for the end plate region, wherein you will get the end plate noise and the end plate spice and end plate spike. If multiple muscle fibers are firing, you will get a complex repetitive discharge. And if the activity is coming from a motor neuron or an axon, it can be a fasciculation, it can be a myokymia, it can be tetany, it can be a cramp, or it can be a neuromyotonia. Then you have to analyze the spontaneous activity for morphology. How is the spontaneous activity? Are you getting an initial negative spike or an initial positive spike, or are you getting a wave, or are multiple muscle fibers, or is this spontaneous activity coming up from multiple muscle fibers, or is it coming from a motor unit? You have to see whether the spontaneous activity is stable or unstable. So when it is stable, it will come at a fixed interval every time. For example, the fibrillation potentials and the positive sharp waves, they are very stable. So they come at a fixed interval. And if they are unstable, you have to see whether it is waxing, or whether it is waxing and waning, or whether it stops, starts, or changes abruptly. And then you have to look at the firing rate. What is the firing rate? Is it very slow, fast, or very fast? And you have to also look at the firing pattern, whether the pattern is regular or irregular. Depending upon this, we differentiate different types of spontaneous activity. I just want to show a video I want to go on the fibrillation potentials, because these are important. So these are known as denervation potentials. They come from a muscle fiber which discharges spontaneously. And when you look at the monitor, they will be single spike-like. They are biphasic, but the first deflection is downgoing, and they have a firing rate which is very regular. And the sound is like a raindrop on a tin roof, or sound of gelatin paper being crumpled. That is why we say that EMG is an audio visual diagnosis. You have to look at the screen, and also you have to listen to the sound that is coming. What is the significance? They are markers of active denervation. They can be seen in neuropathic disorders, radiculopathies, motor neuron disorders, or severe diseases of the neuromuscular junctions. So this is a fibrillation potential. Similarly, positive sharp waves, again coming from the muscle fiber. Here they will be having a brief initial positivity followed by a slow negative phase, and they are long duration, and they sound like a pop on the EMG, and they are seen in active denervation. Mostly they are accompanied by fibrillation potentials. So this is how a fibrillation potential is. A positive sharp wave is seen. So initial deflection which is downgoing, and then a long deflection which is coming. And in this screen you can see there you have positive sharp waves also, and you also have fibrillation potential. One fibrillation potential which is very small, and another which is a very large amplitude fibrillation potential. Now, complex repetitive discharges, these are depolarization of single muscle fiber. When a single muscle fiber, it depolarizes, but when there is a pacemaker, that is the same discharge, it goes round and round around the adjacent denervated fibers. It spreads from one muscle membrane to another muscle membrane. So the depolarization spreads in a circus movement, whereby the original pacemaker muscle fiber is reactivated and a recurrent discharge develops. So when we look in the monitor, you'll see burst-like repetitive discharges, which are polyphasic with multiple small action potentials, and the pattern remains unchanged. The firing rate is regular. And the sound is like a machine-like or a motorboat sound, and it is unchanging. There is no waxing or waning. And complex repetitive discharges are seen in both chronic neuropathic and myopathic disorders, may arise in any setting in which the denervated muscle fibers lies adjacent to other denervated muscle fibers. It can persist with neuromuscular junction blockade. And when we superimpose the sweeps, they will look identical at all the time. So this is one identification marker with the help of which we can determine that this is a complex repetitive discharge. So every time you superimpose the sweeps, they will look identical. Myotonic discharges, they come from myotonic muscle membrane. Again, it is a spontaneous discharge of a muscle fiber, but this has waxing and waning character. It looks like individual, but how does it look like on the screen? It looks like an individual potential. It is like a positive sharp wave or a fibrillation potential, but it fires continuously. And the sound is like a raving engine sound, and it is waxing and waning. And they are seen in myotonic dystrophy, myotonia congenita, and paramyotonia congenita. So these are myotonic discharges, waxing and waning characters. You can see some amplitude, some waves which are larger in amplitude, some waves which are smaller in amplitude. Now, fasciculation potentials, it is a single spontaneous involuntary discharge of an individual motor unit. Now, the source is from the anterior horn cell, motor axon, or terminal nerve fibers. They fire very slowly and irregularly, and they look like a motor unit action potential. And the sound is like the sound of corn popping. They're very dull and irregular. They suggest denervation, mostly seen in cases of motor neuron diseases, may be seen in radiculopathies, polyneuropathies, and entrapment neuropathies also. Benign fasciculations are also present, but when they are present, they are not associated with any muscle weakness or wasting or abnormality of reflexes. In order to look for fasciculation potentials, you have to keep the needle in the muscle, ask the patient to relax completely, and you have to continuously look at the screen, because if you are not paying attention, you can miss a fasciculation potential. So these are fasciculation potentials. They are very slow, irregular, sound like dull pop, corn popping on the corn popping, and they look like a motor unit action potential. Myochymic discharges, they are grouped spontaneous discharges of the same motor unit. So when the same motor unit is firing, and when they are grouped, you'll see myochymic discharges. So again, coming from the motor axon or from the epiphtic transmission along the demyelinated segments of nerve. Again, the firing pattern is regular and the frequency is 5 to 60 Hz. So for fasciculation potentials, the firing pattern was irregular, and it sounds like footsteps of marching soldiers. The significance is it indicates irritative nerve or plexus lesion. They can be seen in hyperexcitable peripheral nerve diseases or myochymic cramp syndrome. So these are grouped discharges. Neuromyotonic discharges, again coming from the nerve, they represent the end of spectrum of abnormal spontaneous activity generated in the motor nerve. Again, bursts of single motor unit potential, they fire very rapidly. And even we can see them with muscle at rest or with needle movement, even if they can come, even if you are tapping the nerve. The burst could be short or long lasting. And the firing pattern, they are very high frequency sounds, they are repetitive, and they have decrementing discharges. And they have a ping and corn popping sound for short bursts and bomber sound for large bursts. And they are seen in hyperexcitable peripheral nerve disorders, also in Isaacs disease or poliomyelitis or intraoperatively when the nerve is irritated. So these are how a neuromyogenic, this is how a neuromyogenic discharge looks like. So they are waxing and waning, and sometimes the bursts are very high frequency, sometimes the burst frequency changes. So when we are looking at the needle EMG, when we are doing the needle EMG, you have to classify the potentials according to the sound, according to the morphology also. That is whether they are regular, whether they are irregular, whether they are waxing and waning, or whether they are only waning, is there any change happening in the potentials when you are listening to the sound. Coming to motor unit action potential analysis. So this is very important. What is a motor unit? It is the basic unit of the peripheral nervous system, and it is an individual motor neuron along with its axon, associated neuromuscular junction, and the muscle fibers. So the extracellular recording of a motor unit is the motor unit action potential. This is the motor unit action potential that we see when we are doing the needle EMG. So when a motor neuron depolarizes to threshold, a nerve action potential is generated and it propagates down the axon. Now, what happens under normal circumstances? This leads to the activation of muscle fibers and then there is depolarization. So if there is any mismatch between the muscle fiber depolarization times, it is mainly because of the difference in the length of terminal axons and the neuromuscular junction transmission times. So motor and action potentials are mostly governed by the size principle. The size of the motor neuron is directly related to the size of the axon, the thickness of the myelin sheath, the conduction velocity of the axon, the threshold to depolarization, and the type of muscle fibers that we are looking at. What is the objective of motor unit action potential analysis? You have to diagnose neuromuscular disorders. You have to differentiate whether a disorder is neuropathic or myopathic. You have to assess motor unit recruitment and muscle reinnervation. We have to also monitor disease progression and treatment response. We do the analysis of motor unit depending upon the morphology. We look at the duration of the motor unit action potential, the amplitude, and whether the potential is polyphasic or not. How stable is the potential and the firing characteristics of the potential. So in morphology, what do we do? Now, motor unit action potential analysis can be done in a quantitative way and a qualitative way. So when we are doing it in a quantitative way, we'll have to look at 20 different sites in one particular muscle. So then it becomes a very tedious task. So that is why nowadays we are doing qualitative analysis of motor unit action potentials. So in morphology, first we look at the duration. So duration is a parameter that best reflects the number of muscle fibers within a motor unit. So what is duration? It is the time from the initial deflection from the baseline to the final return of the motor unit action potential to the baseline. And it depends primarily on the number of muscle fibers within the motor unit and the dispersion of their depolarization over time. Now, duration lengthens as the number of muscle fibers and the territory of motor unit increases, and duration varies directly with age and inversely with temperature. Duration depends on the individual muscle being studied. Typically, the normal duration is 5 to 15 milliseconds. Proximal and bulbofacial muscles have motor unit action potentials of shorter duration. On EMG, duration correlates with pitch. So if a motor unit action potential is of long duration, it will sound dull and thuddy. If it has a shorter duration, it will be crisp and static-like. So normal motor unit action potentials have short duration, therefore they will always sound crisp and static-like. But if the motor unit action potentials are a result of a chronic radiculopathy or a chronic neuropathy, then they will sound dull and thuddy. So you can see in the figure, initial deflection of the motor unit from the baseline to the final return of the motor unit action potential to the baseline indicates duration. So video, just listen to the sound. You'll see as the motor unit is getting activated. So a motor unit which is normal will have a crisp and static-like sound. Again, So you can see there are different motor units coming in, and again, if I am looking at any one motor unit, you'll be able to see the distance in between the two dots which you are able to see on the screen. That is 10 milliseconds. So if we can calculate the duration like this also, the distance in between the initial deflection from the baseline to the final return of that one particular motor unit to the baseline. So in this case, normally on an average, the motor unit duration is approximately 10 milliseconds. What is polyphasia? It is a measure of synchrony. It is the extent to which muscle fibers within a motor unit fire more or less at the same time. And the number of phases can be calculated by counting the number of baseline crossings of motor unit action potential and adding one. So if you are looking at a motor unit, how many times the motor unit crosses the baseline, you have to look at that, and then you have to add one. Normal motor unit action potentials have 2 to 4 phases, and presence of 5 to 10% polyphasics in any muscle is considered normal, but in deltoid it is 25%. So when do we call that the potentials are polyphasic? If it is beyond 10% in any muscle and beyond 25% in deltoid. And polyphasic sound like high frequency clicking sound, and it is a non-specific measure but can be seen in both myopathic and neuropathic conditions, is also an indication of reinnervation. So you can see the normal triphasic potential, then a small potential which has a number of 2 or 3 baseline crossings, but it is a small potential. It is a myopathic polyphasic potential, and a neuropathic polyphasic potential is also shown. So again on the screen you can see this is a neuropathic polyphasic potential. The number of baseline crossings is more than 7. How do we, when we listen to the sound of polyphasic potentials, this is, sorry. Then, as opposed to polyphasia, there is something known as the serrations. Serrations are defined as changes in the direction of potential, but they don't cross the baseline. And increased serrations indicate less synchronous firing of muscle fibers within a motor unit. With additional needle movement also, a serration can change into an additional phase. So this is a figure wherein you can see polyphasic potentials also and serrated potentials also. Now, what are satellite potentials? Satellite potentials are linked potentials. They are seen in early reinnervation because after denervation, muscle fibers are reinnervated by collateral sprouts from adjacent intact motor units. And the newly formed sprout is often small, unmyelinated, or thinly myelinated. And therefore, it is very slowly conducting. Because of the slow conduction time and increased distance, reinnervated muscle fibers are seen as time-locked potentials that trail the main potentials. And satellite potentials are extremely unstable. So these, you can see a satellite potential which is coming after the main potential. So they vary in their firing rate. They may fire or they may not fire at all. And over time, as the sprout goes on maturing, the thickness of the myelin increases and the conduction velocity of this potential will increase. And this satellite potential will now come closer to the main potential, and ultimately it will become a part of the main potential. Now, amplitude is very important. It is generally measured from peak to peak. It is a high frequency response, and motor unit action potential amplitude reflects only those few fibers which are nearest to the needle. It is not as helpful as duration in judging motor unit size, but you still have to look whether the potential is large or small. It ranges from 100 microvolt to 2 millivolt, and factors associated with increased amplitude are if the needle is very near to the motor unit, the amplitude will be large. If the muscle fibers are more, then it will be large. The diameter of muscle fibers is more, again, it will be large. And if there is more synchronized firing of muscle fibers also, you will get large potentials. So amplitude of motor unit action potentials is correlated with volume. So the from the negative, from we have to calculate the amplitude from peak to peak. So from negative to positive peak, that duration, that time is taken as the amplitude, and it is taken in microvolts to millivolts. So when we are looking at the needle EMG, when we are doing the needle EMG, mostly the screen you will see it is in microvolts, 200 microvolts. That is the setting wherein we look for the potentials. And then the two, I'll go back to the slide. In this slide, you will see there are different dots on the vertical axis. And you can see that there's something written as 50 microvolts. So this 50 microvolt is the difference between the two dots. So when I want to calculate the amplitude of this potential, so if I'll calculate the number of dots, that in this there are 1, 2, approximately if there are 10 to 15 dots, the amplitude of the potential will be 50 multiplied by 15. So approximately you can say 750 microvolts. So that is how we calculate the potential. So the amplitude of the potential. So any potential which is greater than 2 millivolt, we call it as large or high amplitude potentials. Then we look for the stability of the motor unit action potential, how stable it is. So every time a nerve action potential is generated, if there is an effective transmission across the neuromuscular junction, all the muscle fibers will fire. But unstable motor unit action potentials occur when individual muscle fibers are either blocked or come to action potentials at varying intervals. So potential changes in either amplitude or phases or both. So unstable potentials will be seen in neuromuscular junction disorders, in myopathic and neuropathic conditions also you can see. Now, again, you have to look at the firing pattern of the potential. So, motor unit action potential, it normally fires in a semi-rhythmic pattern. That is, there is a slight variation in the time interval between the same motor unit action potential as it fires consecutively. So, this property helps to identify the potential as a motor unit action potential under voluntary control. Now, we can increase the force of muscle contraction by increasing the firing rate or by increasing the number of motor units. So force is a combination of these two processes. When we increase the firing rate and also more and more motor units are recruited, so it results in an orderly recruitment of motor fibers, and that is why we get an increase in the contraction of the increase in the force of the contraction of the muscle. So with the smallest contraction, only a single motor unit fires, and the firing rate is 4 to 5 volts. As the force increases, the first motor unit action potential, it increases its firing rate, and then a second motor unit action potential begins to fire. Normally, the ratio of firing frequency to the number of motor units firing is 5:1. And during maximal contraction, multiple motor unit action potentials, they overlap with each other and then they create an interference pattern. So when we are looking at an interference pattern, we will not be able to distinguish a single motor unit action potential. So the maximal firing frequency or the normal firing pattern for a muscle is 30 to 50 hertz. So any muscle, when we are looking at doing the needle EMG and we are seeing the firing rate is very slow, we can see whether it is under voluntary control or not. Again, the same video, which shows how motor unit action potential firing pattern occurs semi-rhythmic pattern. So initially, when we start the examination, we ask the patient to do only slight voluntary contraction. So only 1 or 2 motor units start firing. But when the force of muscle contraction increases, the firing rate also increases. And then again, the recruitment of motor units increases. So you will see different types of motor units coming in as the firing rate increases because the recruitment increases. And then finally we get a interference pattern. So, increasing force depends on activation and recruitment. And activation refers to the ability to increase the firing rate, and this is a central process. And poor activation may be seen in disorders of the central nervous system because of pain if the patient is not cooperating, or in functional disorders. Recruitment refers to the ability to add motor unit action potentials as the firing rate increases. And recruitment is reduced primarily in neuropathic disorders, may be seen in end-stage myopathy. Both reduced activation and recruitment may be seen in patients with motor neuron disorders. So this is a slide which shows the interference pattern. You can make out that in the first slide, you cannot distinguish the baseline in between the two motor units. So this is the maximal interference pattern which is occurring. But in B, you are able to easily demarcate the baseline, and you'll see the potentials are high amplitude potential. So mostly a neuropathic process. In the figure C, you will see the potentials are small in amplitude, and the baseline is not properly seen. So mostly a myopathic disorder wherein there is early recruitment happening. And in the last slide, you'll say that there is very reduced. The firing rate is very slow, and there is no recruitment occurring. Only a single motor unit is firing again and again. So early recruitment refers to the inappropriate number of motor and action potentials firing for the degree of force generated. And early recruitment is seen in cases of muscle and neuromuscular junction disorders. In these disorders, there is a dropout of individual muscle fibers from a motor unit. Therefore, the motor unit becomes smaller and it generates less force. Because each motor unit generates less force, many motor units have to come in so that the muscle fires maximally. So on the monitor, you will see many motor units will fire almost simultaneously with only small amounts of force. So recruitment is more easily evaluated during moderate levels of contraction. So if you are seeing early recruitment, then it might indicate a myopathic disorder. So in this video, you will be able to see even a small force. So large number of motor units coming in, which indicate early recruitment. So, with the help of this recruitment and activation and the motor unit abnormalities that we see on the needle EMG, we are able to classify the disorders as whether the disorder is because of an acute axon loss lesion. In acute axon loss lesion, the motor unit action potential morphology remains normal. Only abnormality that will be seen will be decreased recruitment, that too in the weak muscles. So in acute setting, there will be decreased recruitment with normal morphology on the EMG. In chronic axon loss, what we'll see is there will be some changes in the motor and action potential morphology as well. So after reinnervation, the number of muscle fibers per motor unit increases. So in chronic axon loss, if there is reinnervation happening, you can see there will be increased polyphasics. The motor and action potential has prolonged in duration. It has a very high amplitude and it is polyphasic. And even when you are asking the patient to do maximal contraction, you will not be able to see the complete interference pattern. It will be reduced. So motor and action potential changes along with decreased recruitment is a hallmark of reinnervated motor and action potentials and nearly always imply chronic neuropathic diseases. In demyelinating disorders, again, the underlying axon remains intact. So there is no denervation, reinnervation happening. So the motor unit action potential morphology remains intact. There is no change in recruitment pattern also. In presence of conduction block, there will be reduced recruitment with normal motor unit action potential morphology. In myopathic disorders, if you are looking at acute disorders, the number of functioning muscle fibers in the motor unit decreases. Now there are fewer muscle fibers, so motor unit action potentials will be shorter, will be of shorter duration and shorter amplitude. There will be less synchronous firing, so more polyphasics will be seen. So the pattern in acute myopathy is short duration, small amplitude, polyphasic motor unit action potentials with normal or early recruitment. But in chronic myopathic disorders, some denervation and subsequent renervation happens. So you'll see long duration, large amplitude, polyphasic motor unit action potentials. In many chronic myopathy disorders, there will be two populations of motor unit action potentials are seen, but the recruitment is always early. So how will you differentiate between chronic neuropathic and myopathic disorders? In chronic neuropathic disorders, the recruitment doesn't happen. The interference pattern is severely reduced, whereas in myopathic disorders, there is early recruitment. In end-stage myopathy, actual number of motor unit decreases. So there is an unusual pattern of reduced recruitment, short duration, small amplitude, polyphasic motor unit action potentials either alone or in combination. So these are myopathic motor units which are very small duration. And when we try to increase the force with even the smallest contraction, the whole screen fills up. So early reinnervation following severe denervation, reinnervation occurs either by collateral sprouting or from the regrowth of the axon. So as the axon regrows, it will innervate some but not all the muscle fibers. Hence, the motor unit action potential will be of short duration, small amplitude, and it will be polyphasic. And sometimes you will be able to see some nascent motor units also. But the key differentiating pattern is recruitment. Nascent motor unit action potentials, they will have reduced recruitment. Myopathic motor unit action potentials show early recruitment. In neuromuscular junction disorders, the motor unit action potential morphology and the firing pattern, it depends on the severity of the disorder. If the disorder is mild, the morphology and recruitment will be normal. If the disorder is severe, resulting in intermittent blocking of some muscle fibers, the motor unit action potential will become unstable. If the block increases, the motor unit action potential will become small, short, and polyphasic, similar to myopathic process. Recruitment will be normal or early in cases of neuromuscular junction disorders. In CNS disorders, there is no loss of the anterior horn cell and accordingly no denervation, reinnervation. So morphology and recruitment of the motor unit action potential, it remains normal. There is inability to fire motor units. So the interference pattern is incomplete with a reduced number of motor unit action potentials firing, but the recruitment is normal for the reduced activation. These are my references. Thank you so much.
Thank you, Manisha. I know it is a huge mammoth task, and to finish this we have already overshooted our time.
Yes, ma'am.
And but this was quite interesting, and it's fascinating always to audiovisual EMG and CV. So I don't see any questions in the chat, but anyone who wants to ask any questions, it was self-explanatory. And I think so due to paucity of time, we won't be able to take any questions. Any comment? One comment we can take from, I don't see Amit, but Dr. Abhishek.
I think Amit is in an inspection. He just messaged me. He's currently in a university inspection. Cannot attend the program. But very well done, very well covered, and very comprehensive. Thank you very much.
Thank you so much, sir.
Yes, thank you so much, Manisha. And with this, we end our 10th session of the MAPMR academic sessions. We'll continue this, and we are going to invite from all over India and globally our speakers. And we'll start with Dr. R.K. Srivastav in the next month, which is the first Thursday of May, which is 7th of May. The topic it will be announced, and we'll share it very soon with you. Thank you for joining us, and thanks, Manisha. Thank you, Dr. Abhishek, and thank you, everyone. We'll see you on 7th of May. Thank you.